Welcome back. In the chapter of health programs in India, in today's session we will discuss about National Rural Health Mission. National Rural Health Mission was launched on 5th April 2005 for a period of 7 years. Starting from 2005, it was held for a period of 7 years until 2012. So, guys, we see NRHM, that is National Rural Health Mission, was launched on 5th April. 5th April 2005. Okay, 5 April 2005. 5 April 2005. For a period of 7 years. So, 2005 plus 7 years. For a period of 7 years, it was up to 2012. Recently, it was extended up to the year 2017, okay, plus extended for the next 5 years. The mission seeks to improve rural healthcare delivery system. So, the main mission of this NRHM is to improve the rural healthcare delivery system. Rural's healthcare delivery system. It is operational in the whole country. Rural Health Mission is operational in the whole country. The Rural Health Mission is operational. The special focus of National Rural Health Mission is on the 18 states with 8 empowered action group. We are the 8 empowered action groups. They are mainly focusing on the 18 states. What is the aim of National Rural Health Mission? The main goal is to provide the accessible, affordable, accountable, effective and reliable primary health care. They want to provide the people the health care which is easily accessible. They can access the services very easily. It should be affordable. It should be cheaper so that the community can easily afford it. It should be accountable. It should be accountable enough to take the authority of anything which happens. Accountability, effective, should bring proper results. That is, it should provide the prompt treatment and reliable primary health care. What is the aim of National Rural Health Mission? The aim is to provide the accessible, affordable, accountable, effective and reliable primary health care. Also, to bridge the gap in rural health care through creation of ASHA. So, guys, we see by creating these ASHA workers, that is, ASHAs are allotted for about for each 200 to 500 households. Each ASHA will be allotted one ASHA for every 200 to 500 households. That is the population of 1K to 2.5K. Okay, each ASHA will be allotted. One ASHA worker will be allotted to these households, and they are bridging the gap in the rural healthcare by the creation of ASHA. The plan of action to strengthen the infrastructure. Also, they are planning the actions to strengthen the infrastructure, that is creation of ASHA. So, we know in the next slides we will see how the ASHA is being selected. For now, the creation of ASHA, that is accredited social health activist. Okay. Strengthening of sub-centers. We are strengthening the sub-centers by a supply of essential drugs, both allopathic and Ayush, to the sub-centers. So, we will discuss in detail in the next slide. For now, first thing, creation of ASHA. We are strengthening the sub-centers, strengthening the primary health centers, also strengthening the community health centers so that the referral care can be provided. The plan of action, strengthening the sub-centered PHC, CHC and creation of ASHA. Beginning with the strengthening of sub-centers. So the creation of ASHA I will tell you in detail in the major initiatives. For now, strengthening of the sub-centers. How can we strengthen the sub-centers? So guys, we have community health center in the first place. Okay, community at a higher level, district levels. Then we have the PHCs. Then followed by under the PHCs we have 6 sub-centers usually. Okay, this is the hierarchy. Now, how can we strengthen the sub-centers below PHC? They are at a lower level than PHC. These sub-centers can be strengthened by supplying the drugs, okay, supplying essential drugs. It could be allopathic drugs as well as Ayurvedic, Unani, Siddha, homeopathy, right? Ayush stands for, and this is yoga. We are also providing homeopathic tablets and other required drugs have to be provided to the subcenter. Provision of multi-purpose worker. He could be a male or additional auxiliary nurse midwives whenever it is needed. We have to provide to the subcenters the multi-purpose workers, ANMs, whenever it is needed. Sanction of new subcenters, and we need to upgrade the existing subcenters. Provide sanctions so that new subcenters can be set up. Also, we need to upgrade the existing subcenters. Provision of funds rupees 10k per annum in all the 18 states. So we know the main focus is on the 18 states, like the famous states which were given a greater value to improve the rural health delivery system, where Madhya Pradesh, Bihar, Jharkhand, Chhattisgarh, Uttar Pradesh, Uttarakhand, Orissa, Rajasthan. And we also have this northeast states like Assam, Arunachal Pradesh, Meghalaya, Mizoram, Nagaland, Sikkim, Tripura, Manipur, and so on. So you don't have to memorize all the states. Remember 18 states, out of which some 2-3 names you can list. So these states, we are providing this funds of rupees 10,000 per annum in all the 18 states, so that they can upgrade their center. They can bring in the essential drugs which are necessary. So strengthening of sub centers, how do we do? One, drugs, okay, we provide drugs, both allopathic as well as Ayush. Second, provision of additional ANMs and the health workers, multi-purpose workers. And sanction, we are sanctioning money so that they can upgrade the existing subcenters along with establishing new subcenters. Also, provision of rupees 10,000 per annum in all the 18 states. Okay, sanctioning money so that upgradation can occur, provision of funds, and provision of workers as well as drugs. Now let us see how can we strengthen the primary health centers. The aim is to strengthening the primary health centers for quality, prevention, promotive, curative services. Prevent, promote, curate, as well as supervisory and outreach services. We need to strengthen the primary healthcare centers so that they provide a quality prevention, quality promotive and curative services, supervisory as well as outreach services. How can we provide this? Through adequate and regular supply of essential drugs and equipments to the PHCs. Again, we can strengthen the PHCs by providing drugs, regular supply of essential drugs, and also the equipments to the PHCs, including the syringes for immunization. Provision of 24-hour service in at least 50% of the PHCs, including Ayush practitioner. Okay, we are providing 24-hour service in at least, out of the total PHCs, in about 50% PHCs at least, they have to provide 24-hour service. Okay, 24-hour service should be provided in at least 50% of all the PHCs. Following standard treatment guidelines. Okay, the treatment should be standard. The treatment guideline, the standardized treatment guideline has to be followed by the PHCs. Upgradation of 24 hours referral service. If in case the disease or the case is quite complicated, which cannot be dealt in the PHC, then we refer the case to the higher levels like the CHCs, medical hospitals. So the 24 hours referral service has to be upgraded, and provision of second doctor at the PHC level, that is one male doctor and one female doctor has to be kept. Strengthening the ongoing communicable disease control program. Also the ongoing, whichever the disease control program is ongoing, we need to strengthen it. And also introduction of the new programs for the control of non-communicable diseases. So to cut down the non-communicable diseases, we need to start up new programs. So how can we strengthen the PHCs? Strengthening of PHCs: one, provision of essential drugs and equipments, 24 hour service in at least 50% of PHC, following the standard treatment guidelines, 24 hours referral service. These two together you can remember: 24 hours service, 24 hours referral service, then following standard treatment guidelines. Then we also have to strengthen the communicable diseases control program and bring in new programs for the control of non communicable diseases. Strengthening of community health center for first referral. So we know when a case comes to the PHC, if it is quite complicated and cannot be dealt, we refer the case to the CHC, community health center. So how can we improve this first referral? If CHC cannot be done, then we will refer it to the medical hospitals and private hospitals, public sectors, which are in the urban areas and so on. So we see the first referral, the community health center, which acts as the first referral, operating all the existing community health services centers, that is a provision of 30 to 50 beds. So we are providing about 30 to 50 beds as 24 hours first referral unit. As it is a 24 hours first referral unit, provision of 30 to 50 beds, including the posting of an anesthetist. So we also post an anesthetist so that if any surgery, minor surgeries come, he can take up the thing. Maintaining Indian public health standards. Again, the CHC also have to follow the health guidelines and public health standards by setting up the norms for the infrastructure of the CHC. The staff, equipment, management should be standardized. Maintaining Indian public health standard in terms of the infrastructure, they need to set up the norms for the staff, equipment, management, etc. Promotion of Rogi Kalyan Samiti for hospital management. So when we are studying about Rogi Kalyan Samiti, I'll tell you, which is a very effective management structure where the members, the society members, they will act as a trustee to manage the affairs of the hospital. They provide the better facilities to the patients in the hospital. So the committee members of the Rogi Kalyan, Rogi is the deceased person, so they are, that is patient welfare committee. Kalyan Samiti means the patient's welfare committee, where the individuals, the members of this society will act as a trustee, and they will take up the affairs of the hospital, and they will provide the better facilities to the patients in the hospital. Developing the standards of service as well as the cost in the hospital care. We need to develop the services and the cost at the hospital care. Good amounts would be sanctioned by the government so that they can improve the hospital care, and also the services, which means the equipments, the skilled practitioners. So all of the good services have to be provided in the hospital care. So CHC, guys, what did we study? Beds. We are providing 30 to 50 beds and 24 hours as a 24 hours first referral unit, and we have an anesthetist. Then we have to maintain the standards of Indian public health standards in cases of the and also set up the norms for the infrastructure, staff, equipment, management. Promotion of Rogi Kalyan Samiti for the hospital management, and we need to develop the standards of the service and the standards of the cost in hospital care. The proposed NRHM infrastructure. So let us see the NRHM infrastructure, which is given at the village level. We have Asha worker, Anganwadi worker, village health and sanitation committee, which is for about 1000 population. We have one Asha worker, Anganwadi workers, village health and sanitation committee. At the Gram Panchayat, the sub center level, we have about 5 to 6 villages which come under the sub Gram Panchayats level. And then the cluster of GPs, and we see in the cluster of GPs we have the PHCs covering about 30 to 40 villages. At the block level, we have block level hospitals, which is covering about 1 lakh population, that is 100 villages. At the block level, 1 lakh population. At the PHC level, 30 to 40 villages. At the sub-center level, 5 to 6 villages. Okay. And just 1000 population, Asha workers, Angan Asha workers, they cover about 1000 population. Clear, guys? For each each level, what is the population? At the block level hospital, we have 1 lakh population and 100 villages. At the PHC level, we have 30 to 40 villages. Okay, in terms of village we are speaking, not in terms of population. Villages 30 to 40. Sub center level, we have 5 to 6 villages. And the Asha workers, Anganwadi workers covering about 1000 population. Here you see we have Gram Panchayat at the sub-center level, and the clusters of Gram Panchayats are found in the PHC level. Many villages, right? All the heads, the Gram Panchayats head all together will form the cluster of the Gram Panchayats. Yeah. Now moving on to the major initiatives which are under the National Rural Health Mission. First thing is the creation of ASHA. Creation of ASHA. Who is ASHA? ASHA is an accredited social health activist. How do we select ASHA? The ASHA worker, okay, this ASHA worker, she needs to be Asha worker, she needs to be the resident of the village. She has to be the resident of the village, and a woman, either she could be married woman, or you can take a widow into consideration, or a divorcee. We are not bothered about her marital status. It could be a married woman or a widow or a divorced woman. We have to make sure that she is a resident of the village and she is a female. Asha is a female, preferably in the age group of 25 to 45 years. So we are preferring the age of 25 to 45. Formal education. Her education level, it should be up to 8th class. Okay, she have to study up to 8th class. The communication and leadership qualities. At least her education should be completion of the 8th class. Communication, she should be good at communication. And leadership qualities, okay, she should be extrovert, and then easily mingling, going, because she has to visit the house to house and then mingle with the people, get the information. So she needs to be friendly and sociable enough. So the communication skills are very much required for Asha, and also the leadership qualities. One Asha is allotted for 1000 population, whereas in the tribal and hilly areas, one Asha is provided for per habitation. So guys, what did we see? Asha. Okay, let us try to tell how should a Asha be. This is an Asha worker. Asha worker, first thing, she should be the resident of that village. She is not some neighboring village resident. She has to be a resident of that particular village. Secondly, she should be a female. Obviously, either the female could be women. She could be married, she could be divorced, or she could be a widow. Then preferable age group is 25 to 45. Fourth, we see that her education level should be up to the class of 8th standard, and she should have good communication skills and leadership qualities, so that she can get us the information required and provide the outreach services. Whereas the population, each Asha is covering about 1000 population, whereas in the tribal and hilly areas, one Asha is provided for one habitant. Moving on to the Rogi Kalyan Samiti. I said you the patient welfare committee, where it is a very simple and effective management structure. It is very simple. Rogi Kalyan, it is a simple and effective management structure. They are concerned with the management of the hospital, where the registered society members will act as the trustees, and they will provide the quality health facilities to the patients in the hospital. Also, the financial assistance is provided by these committees to provide the welfare, to undertake the activities of patient welfare. They will also provide the financial assistance to the needy. 31,109 Rogi Kalyan Samitis have been established by the year 2014 of March. Okay, 3000. Now the updated value is 32,005. Okay, now we see the most updated value, 32,005 Rogi Kalyan Samitis have been launched. Moving on to the United Grants to the sub-centers. The sub-centers are now equipped with the blood pressure measuring equipments. Now we are providing the grants to the sub-centers. These grants, with the help of the grants, they are establishing these, the PHCs have been upgraded, wherein we have the equipments like blood pressure maintaining equipment, and hemoglobin measuring equipment, stethoscope, weighing machine, etc. So these basic equipments to check the vitals, the sphygmomanometer, and then we have hemoglobin measuring equipment, stethoscope, weighing machine, etc. So that they will provide the quality antenatal care services, other healthcare services to the people. Moving further to the Janani Suraksha Yojana. The Janani Suraksha Yojana, the aim of Janani Suraksha Yojana, so we see the main aim. The main aim of the Janani Suraksha Yojana is to reduce the maternal mortality rate among the pregnant women. Okay, among the pregnant mothers, they want to reduce the maternal mortality rate. How can they reduce this? By encouraging the pregnant mother to deliver in the government health facilities. They will encourage to perform the deliveries in the government healthcare facilities or the government hospitals. Under the scheme, also the cash assistance is provided to the eligible pregnant women. Okay, if she delivers in the government hospitals or the government health facilities, then we also give her a cash assistance for delivering in the institution. Okay, government institutions. So Janani Suraksha Yojana. Clear, guys? Janani, that is pregnant mothers protection. For the protection of the pregnant mother, we are providing the healthcare facilities, where we are encouraging the mother to deliver in the government health facilities, so that we can reduce the maternal deaths, so that we can reduce the maternal mortality rates. So you can see here NRHM, where we are also providing the antenatal checkup. Institutional care is provided during delivery, and soon after the institutional delivery, the required vaccines to the baby and the mother, immunization is done. So immediate postpartum care will also be provided. Along with this, the cash assistance is given under the Janani Suraksha Yojana, so that we can reduce the maternal mortality rate and as well as the infant mortality rate, and encourage the institutional deliveries in the below poverty line families. Okay, moving forward to the Janani Shishu Suraksha Karyakrama. We had Janani Suraksha Yojana. This was Janani, see, Janani Suraksha Yojana. There's a difference. Janani Suraksha Yojana, we are providing institutional for those who are encouraging institutional delivery, so that we can reduce the maternal mortality rate, and we are giving them the cash assistance along with the antenatal care, postnatal care, etc. Whereas the Janani Shishu Suraksha Karyakram was launched on June 1st, 2011. Okay, it was launched on 1 June 2011. Okay, one for the mother, one for the infant or the baby neonate who is born. So we have Janani Sishu Suraksha Karyakram was launched in the year 2011 of 1st June. It entitles all pregnant women delivering in the public health institutions to absolutely free treatment. Okay, here they are providing the free treatment to the pregnant women who are delivering in the public health institutions. So we see all the pregnant women who are delivering in the public health institutions, they will be treated absolutely free and without any expense. The delivery will be performed, including the cesarean section. So we see the Janani Shishu Suraksha Yojana, where pregnant women who are delivering in public health services, even the C-section will be provided free of cost, along with the drugs and other facilities, the nutrition care. We are also providing free delivery service, including the C-section. National Mobile Medical Units. Now we are moving to the National Mobile Medical Units. All the mobile medical units are repositioned as the National Mobile MMUs, where we are also including nutrition. Okay, so we have the National Mobile Medical Unit Service. Okay, let us focus here now. The National Mobile Medical. Now they have renamed it into National Mobile Medical Unit Service. N is added. Initially it was Mobile Medical Unit. It was just Mobile Medical Unit. And now the National is added. They are repositioned into National Mobile Medical Units with a universal color and design. We have a universal color and universal design. Okay. Now let us see the National Ambulance Service. The National Ambulance Service, the National Rural Health Mission has supported the free ambulance service so that they can provide the patient transport in every nook and corner of the country. So every nook and corner of the country, they need to be connected, and they are connected with the toll-free number, and they are providing the patients with the transport facilities in terms of emergencies in every nook and corner of the country. So we have this telephone number for calling the ambulance. What is the telephone number? Usually 108. Okay, dial 108 for an emergency, particularly in cases of critical care, trauma, accident victims, etc. We need to dial 102 services essentially when there is basic patient transport aimed to the needs of the pregnant woman, or basic transport. We need to dial 102 if she is a pregnant woman and children. Okay. So here we have the dial 108 and dial 102. 108 is during the critical conditions, trauma, accidents, etc. Whereas dial 102 when there is basic patient transport, basic patient like the children or the pregnant women, etc. Moving forward, the web enabled mother and child tracking system. So under the web enabled mother and child tracking system, it is a name based tracking of the pregnant women and the children up to 3 years. The name based tracking. The individual with its name, the individuality is kept here. The name based tracking of the pregnant women, and we are tracking the children up to 3 years so that we can ensure the timely antenatal care and perform the institutional delivery and give the adequate postnatal care of the mother and carry out the immunization schedule. So we see it is fully updated also to provide the effective monitoring of the delivery services, tracking and monitoring the anemic women, low birth weight babies. So we need to take care of the postnatal care of the mother as well as the immunization of the baby, and treat the babies who are severely low birth weight, sick neonates and anemic women. So we are focusing on such people. So now we are moving on to the newer initiatives which have brought in under the National Rural Health Mission. So under the National Rural Health Mission, the main thing, the new thing which has started is the home delivery of the contraceptives, that is the condoms, oral contraceptive pills, emergency contraceptive pills are provided to the doorsteps by this ASHA worker. Conducting district level household surveys. So, in about 26 states and union territories, the annual health surveys is not being done, and we are conducting the district level household surveys. Okay, where the annual health survey is not done, we visit those districts where the annual health survey is not done, and we perform the district health household surveys. Modifications in scheme for promotion of menstrual hygiene. So we are modifying this scheme and we are introducing the promotion of menstrual hygiene, where 1.5 crores of adolescents girls are covered. Next, differential financial approach for comprehensive healthcare. So, we are providing a financial approach to give the comprehensive healthcare by the United Funds, Rogi Kalyan Samiti. They will be, providing the funds based on the caseload and the services which are provided by the health facility based on the caseload, and also the quality of service. These funds will be provided by the United Funds, as well as the Rogi Kalyan Samiti will also contribute and provide the financial funds for the comprehensive healthcare. Involve the ASHA in home based newborn care. Involving the ASHA worker in the home based newborn care. So she will educate about the breastfeeding and how to take care of the baby. Revision in criterion for allocation of funds to the states under National Rural Health Mission based on the performance of the states. So, rather than simply providing the funds, they are revising the criterion, the which state has to be allotted with the funds based on the performance of the states against the targets and how they are implementing the agenda in the health sector. Based on it, we are revising the allocation of funds to the states. Expansion of village health and sanitation committee. Now we see they included the nutrition in the village health and sanitation. So the village health and sanitation is now renamed into village health sanitation and nutrition care. Nutrition is added. Okay, the village health sanitation committee has been renamed into village health sanitation and nutrition care. Moving further, the partial modification of centrally sponsored scheme for development of Ayush hospitals. So we are also modifying the sponsored schemes so that they can develop the Ayush hospitals, dispensaries for mainstreaming of Ayush under the National Rural Health Mission. So we see the modification is done in the centrally sponsored scheme so that they include the development of Ayush hospitals, dispensaries under the National Rural Health Mission. Rashtriya Bal Swasthya Karyakram. Rashtriya Bal Swasthya Karyakram was launched in February 2013. It is providing for the main initiative and provides for the child health screening. The main initiatives are child health screening and early intervention service through the early detection and management of the 4Ds. For the early detection and management of the 4Ds, that is the defects at birth, the diseases, deficiencies, developmental delays including the disability. So they are providing the screening and intervention services so that they can detect and manage the 4Ds. What are the 4Ds? Disabilities, diseases, deficiencies, and developmental delays, including the disability. Rashtriya Kishore Swasthya Karyakram. Now let us see what is Rashtriya Kishore Swasthya Karyakram. This is now a new initiative which is launched in the year 2014 to reach out about 253 million adolescents in the country. So here we are focusing on the adolescents. The interventions are at the community level, where the initiatives is focusing on the adolescents health program. The adolescents health program, beyond the reproductive and sexual health, the main focus is broadening on to the adolescents health. And we are focusing on improving the life skills, nutrition, injuries and violence, including this gender based violence and non communicable diseases, mental health, and substance misuse. So we are focusing on the problems like improving the life skills, promoting good nutrition, and preventing the injuries and violence, that is gender based violence. Focus of the Rashtriya Kishore Swasthya Karyakram is on this. Mother and Child Wings. The Mother and Child Health Wings, MCH, Mother and Child Health Wings, were sanctioned in public health facilities with high bed occupancy, so that the increased demand for the services, to increase the demands for the services, we had this wing of the mother and child health wing, a committee where the wings have been, now the wings have been sanctioned with the public health facilities, so that high bed demand for the services. More than 32,000 additional beds have been sanctioned across the 18 states because of the mother and child health wings. They have brought about 32,000 additional beds to be added into the 18 states. Free drugs and free diagnostic services. So the National Rural Health Mission will provide the free drugs and free diagnostic services. The National Iron Initiative, Iron Plus Initiative. It is another new initiative which was launched in the year 2013 to prevent and control iron deficiency anemia. The main objective was to prevent and control the iron deficiency anemia, which is a grave public health challenge in India. Besides the pregnant women and the reproductive age group, they will be provided with the weekly iron and folic acid supplementation. It is provided for the adolescents, which is an important strategy under this scheme. So these are some of the major important new initiatives. We also have the delivery points and universal health coverage, where the universal health coverage, it is a key goal for the 12th year plan. And comprehensive primary health care is provided to the community. Okay, these are the important things which you have to remember. Thank you. With this, we come to an end of National Rural Health Mission. If you have any doubts, put it in the comment section. And if you like the video, hit the like button.